how the shoulder is affected by the posture, there's certain things that we need to assess. We look at the back in general from the midline of the spine. Is the head tilted to one side or the other? And we can also look to see if there's any thickening or increased muscle on either side of the lateral aspect of the cervical spine. We can look at the upper traps as well. And at first this is all just visual, so we're visually scanning to see is there any increased tone, is there any increased muscle bulk as well. Now, just because someone's got increased muscle bulk, that's not necessarily the sign that that's the key to the pathology. Patients that you see who are overhead activity athletes like tennis players or volleyball players, they will have predominant muscle building and muscle hypertrophy on one side, their dominant arm that they're using throughout their sport. But we just need to scan all patients visually to make sure we can identify these differences. We can look at the scapula, and we've got some really obvious landmarks that we can check with the scapula. We can first look at the medial borders of the scapula here and the inferior angle. So you can look to see, is the scapula winging, so is the scapula raised up off the thorax or is it flat, and is there a difference from right to left as well. We can look to see, is there any visual wasting of the rotator cuff muscles, so do you have any signs of atrophy in the infraspinous fossa or the supraspinous fossa on either side? That might give us a sign that there's been a full thickness tear of the rotator cuff as well. We can look to see where the shoulders sit in relation to the patient's neck as well. Are they protracted and the shoulders rounded around the front of the chest, or is it that it's retracted quite a lot? So we can look at that from a side view. If we just turn Abby around to the side, we can have a look to see where the centre of the glenohumeral joint comes in relation to the ear. So we're looking for it to be relatively in line. Sometimes the shoulders drop their shoulder forward. So if the shoulder slouches forward, that's going to influence the way that the scapula sits on the thorax. In the side view as well, we can also look to see the curves of the cervical spine and the thoracic spine. Now, if someone's got a particularly large thoracic kyphosis, that's going to help protract the shoulder blades as well, and that can lead to poor mechanics of the glenohumeral joint and can lead to some anterior problems or anterior pain in the shoulder as well. So we're looking at the spine, we're looking at the muscles, and we're looking at the scapula itself. When we look at the kinetic chain of how all these muscles influence the body, we can go on and do further objective tests when we look at how the muscles in relation to the patient's lumbar spine and hips even affect the shoulder. And we'll be looking at some specific tests later on. But as a quick scan, you can look, and then once you've had a quick look, then go on and palpate and feel. So you can work gently into the muscles to feel, is there any increased tension in any of these muscles comparing one side to the other. If you do find something, ask the patient, or you will have already found out basically in your subjective that, they're right-handed, they're tennis players. Ask them if anything's sore to touch. You can feel for any increased heat as well, compare one side to the other, or any thickening around the glenohumeral joint. It's important that we also look at the alignment of the acromioclavicular joint as well to see if there's been some previous trauma to the acromioclavicular joint. Has that joint become raised, and is that going to affect the way that the shoulder moves as well?